Hello, and welcome to the CAP Today webinar for Monday, February 7th. I'm Bob McGonnagle, the publisher of CAP Today, and I'll be your host, and I'll also moderate a Q&A session after today's formal presentations. Today's webinar is entitled, Expanding the Clinical Utility of Genomic Profiling in Early-Stage Breast Cancer. This webinar is made possible by a special educational grant from Agendia, and I certainly want to acknowledge them and thank them for their support. It makes a great difference. Our two speakers, and I'll say a little bit more about them in due course, are Dr. William Audeh, who is the Chief Medical Officer of Agendia, and you'll see in his slides a very, very distinguished practitioner and oncologist. And our second speaker is Dr. Hannah Gilmore, and she is the Director of Breast Pathology at University Hospitals Cleveland. Again, I'll say a little bit more about both of them. But first, before we begin, I'd like to just do a little housekeeping for you. We recommend that you go ahead and refresh your browser. That helps us optimally sync up slides and sound. We have live help available at any time. You'll see in the bottom right-hand corner of your screen a number, 858-345-5916. You can call that at any time during today's webinar, and you'll have live help with any technical issue they can help you resolve. As well, you see below the slides a box labeled Q&A. And you can type in any technical concerns that you have also in this box, and they'll be attended to by our staff here on the webinar. But of course, primarily that box is for your questions and your comments as you hear the presentations unfold and the subject matter of the webinar unfold. And you can do that at any time today. As I said, when the formal presentations are over, I'll lead a Q&A session, and we'll get around to every question and comment. If we have anything left over, you'll certainly have your questions answered. I just want to let you know that as well. The audio and slides for today's webinar will be available in about 5 to 6 working days. You can see them at captodayonline.com for review and enjoyment and sharing them with colleagues. You should know that you'll see some follow-up email from us. You'll see that, and so please, that's legit, and hopefully you can help with any questions that are raised in that email. And then finally, as always, it's important that I note that CAP Today does not endorse any product or service that may be mentioned today. And of course, any comments that I make are purely personal. They're not to be taken as the policy of the CAP or today or the College of American Pathologists. And so with that, we'll go ahead and begin. Let me introduce both speakers to you. The first one you'll hear is Dr. Audeh, but I wanted to mention Dr. Hannah Gilmore, who will be speaking after Dr. Audeh, and then they'll be sharing a presentation back and forth in dialogue. Dr. Gilmore trained at the Beth Israel Deaconess Hospital in Boston. She's the Division Chief of Anatomic Pathology and the Director of Breast Pathology at University Hospitals Cleveland at the Cleveland Medical Center in Cleveland, Ohio. And Dr. Audeh, as I said, is the Chief Medical Officer of Agendia. He's got an extensive bio and vita in his disclosures and slides, and he can present that. And so with that, I'll invite Dr. Audeh to begin our webinar. Dr. Audeh.
Thank you very much, Bob. It's a pleasure to be here with you, and certainly to be here with Dr. Gilmore to review several interesting and instructive cases. What I want to show you here as my disclosure and background. I am the Chief Medical Officer of Agendia. I've been in this position for nearly 6 years, and prior to that time, I practiced for nearly 30 years at the Cedars-Sinai Medical Center and Cancer Center, where I held many positions in addition to an academic appointment at UCLA. But I am here now with Agendia, and I want to begin by observing an anniversary that we at Agendia are quite proud of, and that is that approximately 20 years ago, the first publication describing the 70-gene signature, which became MammaPrint, was published in Nature. This really was the first example of gene expression profiling that could predict the clinical outcome of breast cancer, and of course that has now become the clinically available MammaPrint assay that we'll be discussing today. And that initial milestone of research has culminated, as many of you know, in the MINDAC trial. Nearly 7,000 women prospectively enrolled with the results published in Lancet Oncology just that last year. Agendia provides two primary assays, which we will be discussing today, both of which show different aspects of functional genomic profiling of breast cancer. The MammaPrint 70-gene assay, which predicts the potential for distant metastasis, and the BluePrint 80-gene assay, which describes signaling pathways driving cancer growth. Recently, we have obtained further information from the MammaPrint assay, so that now we can identify within MammaPrint both an ultra-low risk as well as a low-risk category. And then within high risk, we also now recognize high 1 and high 2. All of these categories having somewhat different biology and different response to therapy. And then in combination with the BluePrint assay, we identify multiple subtypes which add to the initial classification from pathology. In fact, we identify 5 different hormone receptor positive subtypes, each with clinical implications. And I'll point out that these assays are performed on formalin-fixed paraffin-embedded tissue samples, either the formal surgical resection or, in many cases, the diagnostic core needle biopsy, which yields sufficient tissue and RNA for us to perform our assays, which, as I say, in the ER-positive population, identifies 5 different subtypes. I'm also proud to tell you about a publication that just came out from our research and development team, which takes the genes in MammaPrint and BluePrint and applies them to the hallmarks of cancer, the fundamental and essential characteristics that all cancers possess in one manner or another. And what our team was able to show in a rather elegant scientific review is that virtually every one of the 10 hallmarks of cancer are represented by one or more of either the MammaPrint or BluePrint genes. In other words, we provide really the most comprehensive genomic analysis of the true biology of breast cancer. Also, just a few weeks ago, in the Journal of Clinical Oncology, we had from the MINDAC trial the important results looking at the ultra-low risk cohort within MINDAC. This is one of the low-risk cohorts that we identify with MammaPrint. In this trial, 1,000 patients fell into this ultra-low category, in which the MammaPrint index is above positive 0.355. The outcomes shown here are excellent for this ultra-low risk category. Regardless of clinical risk, you can see at 8 years the breast cancer-specific survival was nearly 100%. And then beyond this important publication, we are also continuing our research with the FLEX study, in which we obtain entire whole transcriptome data from every tumor that is submitted to us for MammaPrint and BluePrint as part of the standard of care. From this, we actually extract the whole transcriptome information and annotate it with clinical data and pour it into a large communal database, which has allowed us to perform multiple sub-studies examining different aspects of breast cancer across our network. Here you see our research network with nearly 100 sites, and as of now, approximately 9,400 patients enrolled, with our total goal of 30,000 whole transcriptomes of breast cancer. This rich database continues to yield a great deal of information, including at the most recent San Antonio, 6 sub-studies shown here, many of which we performed with our external colleagues. So with that, I will hand the reins over to Dr. Gilmore to begin the review of our cases. Thank you, Dr. Gilmore.
Thank you so much, and thank you for having me here today. I'm delighted to be speaking with you about our experiences here at UH and how we have been able to help use genomics to better treat our patients. So case number 1. A 64-year-old patient presents with a palpable breast mass, clinical T3, so over 5 centimeters. There was no axillary lymphadenopathy present on clinical exam or on imaging. The patient's medical history includes diabetes, hypertension, and a recent diagnosis of melanoma that had been completely excised with a sentinel lymph node. The patient underwent core needle biopsy of this breast lesion. So here are some images. It showed an invasive lobular carcinoma grade 2 in a classic type, as you can see here in the H&E on the left. On the right, you see an E. cadherin stain with a nice positive internal control showing loss of E. cadherin, supporting this lobular phenotype. Here, on the core needle biopsy, we performed our ER-PR-HER2. You can see that it's strongly ER positive, greater than 95%, PR negative, and HER2 negative. As is our protocol here at University Hospital, we send the majority of our core needle biopsies from MammaPrint and BluePrint. Here you can see that this patient's tissue was sent, and it came back with molecular subtype luminal B, MammaPrint high risk with an index of negative 0.124. With this information, the patient did decide to go straight to surgery. She had a mastectomy that showed a very large 8.1 centimeter grade 2 invasive lobular carcinoma with negative margins. 0 of 3 lymph nodes were negative, so she's a PT3 and 0. So clinical high risk because she has such a large tumor. The patient really didn't want to take any chemotherapy, and she didn't want radiation either, but she started hormonal therapy with an AI. And within 16 months of follow-up, there's been no disease recurrence. Dr. Audeh, do you have any comments about this particular case?
Yes, thank you, Dr. Gilmore. I think the first thing I'd like to point out is that I'm frequently asked about data with MammaPrint in invasive lobular breast cancer because most of the data that have been generated focused on invasive ductal cancer patients. And I wanted to describe 2 studies that actually describe in some detail the performance of MammaPrint in identifying risk in invasive lobular cancer. Here was a collection of, I believe, 5 different studies, which amounted to 217 cases of invasive lobular cancer for which MammaPrint was provided. And what you can see here is that MammaPrint clearly distinguished low risk from high risk lobular breast cancers by multiple clinical parameters, including overall survival, distant metastasis-free interval, and distant metastasis-free survival, essentially illustrating that although we think of lobular breast cancers as relatively unaggressive or less risky tumors, there are clearly high-risk tumors that MammaPrint can identify genomically. More recently, from MINDACT, the large study that enrolled nearly 7,000 patients, it had been reported at a European study and in a manuscript soon to be published that 487 of these patients enrolled were of invasive lobular type. 255 were classic ILC, and 232 were variant ILC, which includes pleomorphic lobular breast cancer. And what I'd like to point out from this data, again, for the genomic high-risk group, is that within the high-risk group of the invasive ductal cancer, IDC, 39% were high risk, while in the lobular cancer, not surprisingly, only 16% were high risk. However, those high-risk lobular cancers identified by MammaPrint still had a somewhat worse 5-year outcome than those that were low risk by MammaPrint. And I think the point here is that MammaPrint accurately identifies high-risk lobular breast cancers from those that are low risk, despite our assumptions regarding lobular breast cancer. One other point I'd like to make, which is that this is a hormone receptor positive breast cancer with a high risk MammaPrint result, is that we've also recently presented data from the NSABP B42 regarding the benefit of extended endocrine therapy. And while this patient has embarked upon her first 5 years of endocrine therapy, if she's able to tolerate that treatment and completes the full 5 years, the question is routinely raised as to whether she would benefit from extended endocrine therapy, as was shown in the B42 trial. The original trial results shown on the far left show that there was an approximately 4% improvement in disease-free survival with the addition of an additional 5 years of letrozole. However, when we applied the MammaPrint assay to this large cohort of patients, we observed that it was only the low-risk patients who were not in the ultra-low category, shown in the middle bars there with the green arrow, who really benefited from extended endocrine therapy. And patients such as yours today, Dr. Gilmore, with a high-risk MammaPrint, at least according to this trial, would not be expected to benefit from continuing beyond 5 years of therapy. In fact, the benefit was 9.5%, but again, that was limited to the low-risk patients. So with that, we can go to the next case.
Thank you. So case number 2. A 65-year-old patient presents with a mass on screening mammography. No axillary lymphadenopathy was present on clinical exam or on imaging. The patient is a smoker with hypertension, but otherwise no significant medical issues. The patient underwent a core needle biopsy of the breast lesion. So here's a picture from the core needle biopsy. It's a little hard to tell at low power exactly what's going on, but on higher power, there were some very poorly differentiated tumor cells scattered throughout this core needle biopsy. We did some immunohistochemistry to confirm the diagnosis, and what you can see here is this is really a poorly differentiated invasive ductal carcinoma. The pancytokeratin lights up. You can see the LCA is positive around, showing all the different surrounding lymphocytes, and the GATA3 was positive, supporting the diagnosis of a primary invasive carcinoma of the breast. We did ER, PR, HER2, and despite the fact that it was very poorly differentiated, enough that we ordered all these special stains on core, it was ER positive, greater than 95%, PR more weakly positive, 5 to 10%, and HER2 negative. As is our protocol, we sent this because it was ER positive for MammaPrint and BluePrint. And to our surprise, because this was so strongly ER positive, as well as had some PR positivity, by BluePrint, she was basal type molecular subtype, and MammaPrint result was high risk with an index of negative 0.633, indicating here on the report that the probability of a pathologic complete response would be very high with neoadjuvant chemotherapy. Here again, you can see the same thing on the graph. You know, whenever I get these results that are a little bit unanticipated, I always like to pull these. If you look deeper in the report, you can see the MammaPrint and BluePrint results, and just look to see how the algorithm decided which particular type it would be. And I always find it very interesting to look at these numbers to show that while this is basal type, you can see that it's definitely not HER2 type, but the luminal type less so. But there isn't a huge difference between those two. I always find this very interesting whenever However, there's kind of a little difference between what I expect on the MammaPrint BluePrint report and what I see by just traditional ER/PR/HER2 staining. So the patient's invasive ductal carcinoma grade 3, high clinical risk and high genomic risk. She opted to proceed directly to surgery in January of 2022 and had a mastectomy with sentinel lymph nodes. At surgery, the patient was found to have an invasive ductal carcinoma, grade 3, 1.7 centimeters with negative margins. All the lymph nodes were negative, so a PT 1C N0. The patient is really unsure about chemotherapy, which is why she went to surgery and radiation, but would consider an aromatase inhibitor. So I thought this is a really interesting case from a clinical management perspective. Dr. Audeh, do you have any comments about this case?
Yes, Dr. Gilmore, thank you. As you pointed out, the genomic result of basal appearing to be the dominant subtype with really no evidence of hormonal signaling is not what you would expect with a tumor with such a strong estrogen receptor expression. However, that is indeed what we have seen in these so-called ER-positive basal breast cancers. What I'm showing you here are data from our neoadjuvant trial known as NBreast, from which we've produced several publications. These data look specifically at this hormone receptor positive but genomically basal subtype. On the left, by the percentage of IHC expression of both ER and PR. And while you might expect that an ER-positive basal tumor would have very low estrogen receptor expression by IHC, that is not actually the case, as was the case in your patient. In fact, you can see the range of estrogen receptor that can be detected by IHC can be nearly 100%. There certainly is a clustering at the lower end of the range, but the majority of these tumors are above 10% and would be considered estrogen receptor positive. Progesterone receptor is somewhat more informative in that we rarely see these ER-positive basals with progesterone receptor above 50%, but both can be positive, as was the case with your patient. On molecular analysis of this entity, which can make up between 13 and 25% of hormone receptor positive patients, we did find that the estrogen receptor gene, the ESR1 gene, is normal and not mutated, but there is a defect in the splicing of the mRNA that yields a partial protein which is non-functional. It can still be detected by IHC, but it doesn't appear to produce any functional signaling, which is why its biology seems much more similar to a triple-negative breast cancer. And that explains, as shown on the right, the very high chemosensitivity of this particular type of estrogen receptor. It is genomically basal, which is very similar to triple-negative as defined by IHC, and you can see the PCR rates here. Very different from those truly luminal tumors on the right. We also have provided longer-term outcome. This was presented at San Antonio in 2020. And this takes that BluePrint identified subtype of estrogen receptor positive breast cancers and shows their long-term outcome by PCR. And the important finding here is that the basal tumors that achieve a PCR if they're given neoadjuvant chemotherapy, shown in green, do quite well despite the aggressive biology. But if they do not have a PCR, their 5-year probability of distant metastasis-free survival is just below 60%, very much like a triple-negative breast cancer. This patient would be best managed with chemotherapy if she were willing to take it, because it does not appear that there's significant estrogen receptor signaling that would be adequately treated by an aromatase inhibitor alone.
So next case, case 3. A 47-year-old patient presents with an abnormal mass detected by screening mammography. The patient is premenopausal with no significant medical history. There was no axillary lymphadenopathy present on clinical exam or on imaging, and the patient underwent a core needle biopsy of the breast lesion. So you can see here the H&E. This is an invasive ductal carcinoma. You can see very good tubular formation, and this is a grade 1 invasive ductal carcinoma. So not surprisingly, this grade 1 invasive ductal carcinoma was very strongly positive, ER positive greater than 95%, PR low positive 5 to 10%, and HER2 negative. As is our protocol, we send these for MammaPrint and BluePrint. We can see here that this patient has a molecular subtype luminal A cancer. The MammaPrint result was low risk, and it wasn't just low risk, it was in this ultra low range above 0.355. In fact, this patient had a MammaPrint result of 0.503. So she has an invasive ductal carcinoma, grade 1, low genomic risk in a premenopausal woman. The patient opted to proceed directly to surgery, and she underwent a lumpectomy with a sentinel lymph node biopsy. At the time of surgery, the patient was found to have an invasive ductal carcinoma, grade 1 confirmed, 1.1 centimeter in greatest dimension with negative margins. A micrometastasis was present in one of 4 lymph nodes, so she would have PT1C and 1MI. And now, given all these risk factors, the patient presents for a discussion of adjuvant treatment options. So Dr. Audeh, would you please comment on this particular patient and how you think that she might be best served?
This woman falls into a category of newly diagnosed breast cancer that has seen quite a bit of controversy recently. She's premenopausal and node positive with hormone receptor positive breast cancer. And as you know, 2 large trials, actually the largest of their kind in hormone receptor positive breast cancer, have recently been published, the RxPONDER trial and the MINDACT trial, both of which looked at this particular population. MINDACT, in looking at the hormone positive, HER2 negative, node positive patients, which included micrometastatic disease, by the way, these data were first reported in 2016 in the New England Journal of Medicine, where we did show that with a MammaPrint low risk such as this patient had, that there was really no benefit to the addition of chemotherapy despite being node positive. These data were actually the first prospective and randomized data in a node positive cohort to show that we could identify with a genomic assay a group that did not require chemotherapy. And this led to MammaPrint's inclusion in the ASCO guidelines in 2017. More recently, we had the long-term follow-up now with an average of 8.7 years from this same MINDACT trial. And this showed that the outcome of these MammaPrint low risk lymph node positive patients was still quite durable out to 8 years with no significant benefit to the addition of chemotherapy. And this remains the only prospective randomized data with such long-term outcomes in node-positive patients. But there's another issue here, which is the patient's age, which is where the controversy has come. Because in both MINDACT and RxPONDER, of course, the question was raised as to whether age matters in genomically low-risk women. And here I'm showing you the data from MINDACT, which showed in clinically high-risk but MammaPrint low-risk patients, the outcomes determined according to age. Now, these clinically high-risk women in MINDACT were a combination of node-positive and clinically high-risk node-negative patients. And what we saw was that at 5 years, the chemotherapy arm had a 2.6% benefit, and at 8 years, 5% benefit. While in a group with identical clinical features and identical low-risk MammaPrint, but over 50 years of age, there was no difference of any significance. So the question was raised as to whether hormone receptor positive cancers in women such as yours premenopausal under 50 are actually biologically different from cancers in women over 50? Or is this differential effect that we're seeing actually a different effect of chemotherapy on the woman herself? In other words, is this a secondary ovarian function suppression by chemotherapy rather than direct cytotoxicity? One piece of information that we generated from the FLEX trial that I mentioned earlier today was presented at ASCO last summer. And because we had the power of the whole transcriptome data, as well as MammaPrint and BluePrint results, we took a large cohort of women with hormone receptor positive breast cancer that were 50 years or younger, and compared their whole transcriptome from their tumors to tumors that were also hormone receptor positive, but in women who were over 50 years of age, and they were matched by clinical stage and other features. And if there had been a genomic difference, a true biological difference due to age alone, the blue dots representing the younger women and the red dots representing the older women would have been separated as different clusters showing different biology. But as you can easily see, the genomic profiles were superimposed on each other, providing one piece of evidence that there's no indication, at least by gene expression, that there's any biological difference due to age when you hold other things constant, such as MammaPrint risk and hormone receptor positive subtype. So because of this lack of any difference in whole transcriptome gene expression, we would argue that there's really no difference in biology either due to age in these low-risk women. And it supports the hypothesis, although it doesn't prove it, but it certainly provides support that the benefit of chemotherapy that we saw in these women under 50 was more likely due to secondary ovarian function suppression than due to some biological and intrinsic difference in their tumors. I'll also point out that from our exponder, which also showed a significant benefit to chemotherapy in women who are lymph node positive and premenopausal, regardless of having very low recurrence scores between 0 and 25, they actually saw a chemotherapy benefit as well. And one of the conclusions of our exponder has been to advise or consider chemotherapy in such women. At this last San Antonio, a further update from our exponder in an unplanned subset analysis I find to be extremely informative. What they looked at was the loss of periods due to therapy. And what you can see that regardless of whether periods were lost due to endocrine therapy alone on the left or due to chemotherapy on the right, that women who lost their periods did better in general. When you look at the 8-year point and at the group in blue that no longer had periods as a result of either endocrine therapy or chemotherapy, their outcomes were the same and clearly better than those who did not undergo menopause as a result of their systemic treatment. My interpretation is that women who stopped having periods by year 2 had better outcomes, as shown in our responder, regardless of whether it was chemotherapy or endocrine therapy that ended up stopping their periods. Again, this seems to me to be proof of the benefit of ovarian suppression. And so this young woman that you've described, Dr. Gilmore, I do not think requires chemotherapy, even though she's premenopausal and would have been observed to benefit from chemotherapy from our exponder. But all the data really seem to suggest that she could be adequately treated with ovarian suppression and an oral agent such as tamoxifen or an aromatase inhibitor. And this really would be reasonable to offer to her as an option. That is why, in fact, when we talk about the clinical application of the MIND-ACT results, when it comes to premenopausal women who are either node positive or clinically high risk based upon tumor size, we believe that OFS or chemotherapy are reasonable choices.
So thank you. So next case, case 4. This is kind of an interesting case that's a little different from the others. A 75-year-old patient presents with a 6-millimeter mass on screening mammography. There was no axillary lymphadenopathy on clinical exam or imaging, and she underwent a core needle biopsy at an outside institution. Her past medical history included hypertension and coronary artery disease. Review of the outside biopsy showed an invasive ductal carcinoma, grade 3, that was ER and PR negative. HER2 was equivocal by immunohistochemistry, and by report, HER2 was amplified by FISH with a HER2 CEP17 ratio of 2.0, an average copy number of 6.3. The patient decided to proceed directly to surgery. So she had surgery at our institution, and it revealed an invasive ductal carcinoma, grade 3, 1.2 centimeters, margins negative with a negative sentinel lymph node. Receptors per protocol were repeated on surgical excision internally. ER and PR were negative, similar to the prior core needle biopsy findings, but when we repeated HER2 on the patient, we got what we call 2+ is what we recorded, but a high 1+, low 2+. For those of you who read a lot of HER2s, we know there's sometimes a little bit of a distinction, and the control worked very well that day. So we reflexed the case to ISH. We had several different people look at it, and though we looked all over the tumor in lots of different spots, we could not get a positive HER2 result by in situ hybridization. It fell into this group 4 category where we had multiple observers blindly counted. And it is noted in the ASCO-CAP guidelines when we get this result that we are not to consider it positive. Now, this is really complicated because on the core needle biopsy before, the patient had a HER2 positive result by ISH, although it was pretty right at the threshold of 2.0. So everyone agreed that this patient needed chemotherapy, but the question is, of course, which type of chemotherapy the patient should get. So we sent it off for MammaPrint and BluePrint. And not unexpectedly, this showed a high-risk MammaPrint result. Given the grade 3 and the ER-PR negativity, we anticipated that. But what we thought was really interesting is that from a molecular standpoint, this was behaving like a basal type, not a HER2 positive type, with a probability of a pathologic complete response of 34%. Now, this patient had surgery before, and so we knew we were sending this mostly because we were trying to figure out which type of chemotherapy would best serve this particular patient. So after much discussion at Tumor Board and lots of talk between many people on the multidisciplinary team, the patient underwent a triple-negative breast cancer adjuvant chemotherapy regimen with adriamycin and Cytoxan, followed by Neulasta. The patient's well 18 months after additional diagnosis with no evidence of disease. Found it interesting, some information coming out of San Antonio this year. This is from the Memorial Sloan Kettering group, and they were using their own assays. But they showed a whole series of patients who, though they were clinically HER2 positive, ones that were genomically not HER2 positive, again by different assays, it was noted that those patients tended to have poor progression-free survival than those who had the ones that were HER2 clinically positive, but genomically HER2 not overexpressed. So I think this is a really interesting case. It's a little bit of a different use for the MammaPrint BluePrint test. But Dr. Audeh, I was wondering if you had any comments about this particular case.
Yes, certainly it is very interesting, especially to see the expression of HER2 that identified by various techniques, but yet not borne out at the genomic level with evidence of HER2 signaling, which would have certainly directed therapy in a somewhat different direction. But I think it underlines the importance of thinking about the diversity within tumors that are expressing HER2 to some extent. Going back to the NBreast neoadjuvant trial that I mentioned earlier, that was a trial that enrolled nearly 1,100 patients who were intended to receive neoadjuvant therapy. And they were initially identified by standard pathology, as you have done with your patient, using immunohistochemistry and FISH. And the three main categories of hormone receptor positive, HER2 receptor positive, and triple negative were all included. And they were treated with neoadjuvant regimens directed by the standard immunohistochemistry. The purpose of this trial, however, was to apply the MammaPrint and BluePrint assays to the same sample that had been used for the preoperative immunohistochemistry to see whether there was further classification that the BluePrint and MammaPrint could provide beyond the three main categories, and perhaps consider whether that additional classification would have clinical implications. So what I wanted to focus on was that within the HER2 receptor positive group, and I'll point out this is a group that was unequivocally positive, unlike your patient, we were still able to see, as you can see from this Sankey diagram, where the HER2 positive group is then separated with further classification by BluePrint based on gene expression. That separates into multiple different subsets. This is the same as what we've seen in the estrogen receptor positive group as well, where we can identify multiple different genomic subtypes. And in both the estrogen receptor group, as we mentioned in a previous case that you presented, Dr. Gilmore, as well as this particular case, there is a proportion of both HER2 positive as well as ER positive patients that turn out to be genomically basal. And what that means is, in the case of HER2 positive patients, not that there isn't some HER2 signaling, but that it is, let's say, less important in the biology of the tumor than the basal biology, which is not so dependent on that HER2 signaling for its growth. And as you pointed out in that San Antonio abstract, we have also seen that these basal tumors do have worse outcomes over time than other hormone positive and other HER2 positive cancers. So basal biology is represented in these subsets of tumors identified by IHC and FISH. I'd like to make one more point here before we move on, and that is that you pointed out that the MammaPrint index was quite high. In fact, it was in the range that we would call high 2, which is something that has been identified initially by the I-SPY study, in which within the MammaPrint high-risk group, we can separate high risk into high 1 and high 2, and we find that the high 2 group is more chemosensitive than the high 1 group. The cutoff between them is at minus 0.57, and I believe that your patient's MammaPrint index was in that high 2 group. And what the I-SPY study has shown is that the high 2 group identified by MammaPrint is more sensitive to immunotherapy, more sensitive to carboplatin, and more sensitive to PARP inhibitors. So we suspect that there's additional information to be gained by looking not only at whether a tumor is MammaPrint high risk or low risk, but also looking at whether they're in the high 1 or high 2 category. And because this tumor is basal, this would seem to be a tumor that needs aggressive chemotherapy appropriate for stage. That would be the same type of treatment you would use for a triple negative breast cancer.
Case 5. A 76-year-old patient presents with an abnormal area of asymmetry detected by screening mammography. No axillary lymphadenopathy was present on clinical exam or imaging. The patient does have multiple comorbidities, including atrial fibrillation, chronic kidney disease, and heart failure. The patient underwent a core needle biopsy of the breast lesion. So here you can see on the H&E and nice ecadherin showing positive staining, supporting the ductal phenotype, that there was an invasive ductal carcinoma grade 2. I'll point out that it was actually fairly small on core needle biopsy, only 3.5 millimeters in linear extent, but in our experience, that is ample tissue in order to get a genomic result. Here you can see here that it is strongly ER positive, greater than 95%, PR positive, greater than 95%, and HER2 negative. This core needle biopsy material was sent for both MammaPrint and BluePrint. And what you can see here is it's a molecular subtype luminal A. It is a MammaPrint result of low risk, and not just low risk, it's this ultra low risk, 0.520. So it falls into that ultra low risk category. You can see here on the graphs that show up nicely with the report that the average 10-year risk of recurrence untreated is 10%, and that this patient's score falls soundly within the low risk range. So she has an invasive ductal carcinoma, ultra low genomic risk. The patient underwent a lumpectomy. She was found to have an invasive ductal carcinoma. It was grade 2. It was small, 7 millimeters in greatest dimension, with negative margins. A sentinel lymph node biopsy was not performed because of the clinically negative axilla comorbidities and age, just part of the Choosing Wisely campaign. The patient is considering taking an aromatase inhibitor. So Dr. Audeh, what are your comments about this particular case?
Well, this is a small hormone-positive tumor with an extremely low-risk genomic profile, ultra-low risk by MammaPrint, and we have a great deal of data showing the excellent prognosis as well as the benefit of endocrine therapy for this particular type of patient. As you've pointed out, we define the ultra-low risk range within the low-risk MammaPrint as greater than 0.355. Although I will point out that the majority of low-risk patients are actually in the low-risk but not ultra-low, there's a substantial portion that are ultra-low, which can range anywhere from 15 to 25% of these women, particularly in a mammographically screened population, whereas we all know we are able to find these more indolent cancers. We published on this entity beginning in 2017 with a publication from Dr. Laura Esserman and colleagues in Sweden, where they looked at one of the original Stockholm tamoxifen trials in which women were actually randomized after surgery. These were postmenopausal women with tumors 3 centimeters or less. They were randomized to receive only surgery and no further systemic therapy or some amount of endocrine therapy, which at the time of this original study back in the 70s and early 80s was limited to tamoxifen. So what you can see here is the results of this analysis that was done on the original Stockholm trial. They were able to take the old FFPE blocks, extract enough RNA to run MammaPrints, and found that from that original group, approximately 15% had an ultra-low risk MammaPrint. The great benefit of this Stockholm trial was that they had 20 years of follow-up of these patients. And so what you see here is the long-term outcome of these women who were postmenopausal and ultra-low risk by MammaPrint, treated with either 2 or 5 years of tamoxifen in the solid green arm, or no treatment at all in the dotted green arm. And regardless of treatment, they did exceedingly well out to 20 years. If they received any tamoxifen at all, they had a 97% 20-year breast cancer-specific survival. And if they hadn't received any treatment, a 94% breast cancer-specific survival at 20 years. That survival rate was approximately 100% at the 10-year mark for these ultra-low risk patients. Now we have additional data that has just recently been published, as I mentioned at the beginning of the hour, on the outcomes of these ultra-low-risk patients from the MIND-ACT trial. So this was really the first large cohort of prospectively enrolled ultra-low-risk patients, 1,000 in this trial. And I'm having some trouble moving the slide forward. Are you able to move the slide forward?
I cannot either. I don't know if it's a glitch.
This seems to be the last slide in the set.
Well, maybe that's why.
Yes.
This large cohort included patients who were postmenopausal and who were ultra low, and they had a very similar long-term outcome as we saw in the STO trial, suggesting that these patients can do extremely well with certainly the 5 years of standard endocrine therapy. But in the case of significant toxicity, the STO trial showed that they could safely receive less than a full 5 years and still have an excellent outcome. In fact, within these 1,000 patients in the MIND-ACT trial that were ultra low, nearly 160 of them elected not to receive any systemic therapy at all, and their 8-year breast cancer-specific survival was nearly 100% as well. So this is a patient who should certainly start on endocrine therapy, Dr. Gilmore, but if she ends up having significant toxicity, the data suggests that she could safely discontinue her treatment.
Thank you, Dr. Audeh, and thank you, Dr. Gilmore, for a very compelling presentation today. We've seen a lot of new and recent research that's quite important. We've seen 5 important and interesting cases that I think in some ways represent an entire spectrum of problems that clinicians and pathologists confront in breast cancer and what to make of it. And so I want to thank you for that very much. We do have some time left, a few minutes, if you'd like to make a comment or ask a question. You can type that in now. Let me start off first. I'm going to ask you, Dr. Gilmore, several times during the presentation you alluded to your protocols for sending out specimens for these assays. Are those protocols always in constant evolution, depending, as we've seen from many, many studies, many of them new, that you see on these 2 assays?
Yes, thank you for that question. So we have a very cohesive breast cancer medical management team, and we constantly discuss what types of testing needs to be done. Obviously, things like ER, PR, HER2, we do automatically per ASCO-CAP guidelines. But we made the decision back in 2020 that having genomic information at the time of coroneal biopsy was very important, particularly in the ER positive and HER2 negative or HER2 uncertain or equivocal setting. And that has really been transformative for us, understanding not just how the patient presents and just the traditional clinical pathologic factors, but having that genomic information up front. I think patients find it very helpful to know early on in the course of the disease, and it helps us as a breast program really triage how patients should get treated.
Thank you. And Dr. Audeh, I just want to ask you to comment on that same question.
Yes, I think that there are many different approaches to the application of genomic data. I think more and more we're seeing many centers like Dr. Gilmore's employing the routine use of genomic information as early as possible, particularly because of the technical ability to extract enough RNA from a core needle biopsy to allow us to perform the MammaPrint and BluePrint assays. And in fact, within our FLEX study, we can do the whole transcriptome as well. And these cases that were selected by Dr. Gilmore, I think all illustrate that the genomic information is complementary to the pathology information, in that in cases where there may be additional biological diversity underneath the ER, PR, and HER2, that looking at the level of gene expression certainly adds useful information.
Thank you.
And, before we go on to other questions, I actually had a quick question for Dr. Gilmore myself, which is, Dr. Gilmore, I just wanted to ask you to comment, because I didn't ask you earlier, on your opinion about grading in lobular breast cancer, because I've heard different things as to whether grade is a relevant aspect of lobular breast cancer or not, and what kind of agreement there is between pathologists.
Thank you for that question. So we grade based upon, the Nottingham, the modified Bloom-Richardson criteria. So we look for tubular formation, size, nuclear pleomorphism, and mitotic rate. And some of that, we do our best to standardize as pathologists. There is a little bit of inter-observer variability, and for lobulars, they always get 3 points for, because they don't form tubules, and they very rarely are mitotically active. So you're dependent on a pathologist deciding how big the cells are, how much pleomorphism is. And I find that some pathologists are a little bit less likely to call grade 1. Some are more likely to call them grade 2. In the original Nottingham studies, there was a separation between grade 1 and grade 2. So I think, and it's funny because when you think about it, so many of these, the majority of these are low grade, but I think it's something that all of us struggle with as pathologists, and I think there is some inter-observer variability.
Thank you. I think in part that does also support the benefit that may be gained from the genomic analysis that can take some of these patients with maybe intermediate grade and classify them further as high risk or low risk based upon gene expression.
Yeah, I agree. I think it's very helpful information.
We have one more question here, which may, in fact, prove to be our final question, but let me read it to you. I'll ask Dr. Audeh to comment first, and then naturally I'd like Dr. Gilmore. But the question is as follows. For patients that have multiple tumors, whether morphologically similar or different, is it recommended to test all tumors or just the, quote, most aggressive, unquote? Dr. Audeh.
Yes, that is an important question, because we do see many such cases arising. And I think there are two ways to answer this. One is that if the information that you are seeking is simply the chemotherapy or no chemotherapy answer, then the tumor that appears to be most aggressive is the one to test, because it is the most likely to yield a high-risk genomic profile if that is indeed reflective of its biology. And if, again, your only question is, does it require chemotherapy or not? Once you get that answer, yes, it does, you don't need to test anything else. However, what I hope I showed you today were examples of additional information that's provided that would be relevant not for the most aggressive tumors, but also for the least aggressive tumors. In other words, you might wish to know if a tumor is ultra low or low, whether there's benefit to extended endocrine therapy, or in the case of a low risk tumor, whether it might be ultra low treated not simply without chemotherapy, but perhaps even able to stop early. So I think there are reasons to perform genomic testing beyond just to answer the chemo, no chemo question, but rather to also answer some questions about endocrine management, which suggests that perhaps not just the most aggressive should be analyzed to get that additional information.
Thank you. And Dr. Gilmore, could you comment on this same question?
Yes. So typically, what I do as part of my breast pathology group here is if the tumor all looks the same, we note that in our report that it's all morphologically similar, but it's perhaps just multifocal, and we test the larger tumor. And usually, if we're thinking it's the same tumor, we leave it at that. If it looks like they're different separate tumors, we usually do start off with the most aggressive one, and then depending on, as a clinical team, we'll take that result. And if there are reasons to test the other morphologically distinct tumors, as Dr. Audeh pointed out, if it's a choice of whether to give endocrine therapy at all or choices for chemotherapy, then we'll go ahead and do that and test that on a per patient basis. And, sometimes there are patients have two morphologically distinct tumors with very different biology, so it does happen.
Thank you. Thank you very much. And with that, I'm going to give you the last word for this afternoon and begin to sum up. I want to thank Dr. Bill Audeh and Dr. Hannah Gilmore. They have given us a wonderful presentation, and I'm just delighted we were able to present that to you. Or let me remind you, it can be reviewed on captodayonline.com, both the full audio and the slides, and so I'm sure you'll want to take advantage of that. That should post in about 5 or 6 days. Once again, I want to thank Agendia. Their special educational grant supported this program, and I want to acknowledge that. I'm very grateful for that. And finally, I want to thank all of you. I know we're dealing with short staffing across the board. We're coming out of another trough of COVID, but who knows where we're going. And it still is a Monday afternoon, so I'm especially grateful for all of you for tuning in with us. So once again, let me thank Dr. William Audeh, Dr. Hannah Gilmore, Agendia, and all of you for your participation in today's webinar. And with that, I'll bring this webinar to a close.